This is one of the most important sections that is required for oxygen conservation today in this country. And this section is all about the oxygen weaning protocol. Now I'm not a medico, but obviously when we work into the oxygen audits, we understand all of this. And I'm going to try to put it in a layman's language so every doctor, every nurse, every paramedical staff and every biomedical engineer understands this most important section, that is the oxygen weaning protocol. Now what does this oxygen weaning protocol say? Each state, each country has its own standard, but by and large what we follow here is the patient, if he is maintaining at 92% SpO2, is good. Now yes, there is a SpO2 and there is a FiO2 and then there is the PO2 and there is the automatic biogas analyzer. So I am not going to too much of complexities. For the common person to understand, we will refer it as SpO2. While I am sure my medical friends would understand the differences in all of them and at the right point know which kind of O2 level to check. So SpO2, first of the most important step which are missed by the most of the hospitals in India is using an oximeter which also has SpO2. It is having a respiratory rate mechanism, a mechanism to check RR, respiratory rate, and a mechanism to check the pulse. Now what we should understand over here is that if you use a very cheap oximeter, there are a lot of fluctuations, and in the long run it could be very costly for you, and it can make a lot of difference to the patient also. Thus use a very good quality of oximeter is the fundamental foundation on which the oxygen weaning protocol is based. Correct measurement of oxygen levels, I would say. So beyond the measurements for the patients on the ventilators, in the ICUs, there has to be periodic checking of ABG being done, and this is important to establish their PO2 levels, to establish at what level the oxygen delivery mechanism has to be set to the patient. Now let us look what is it here. So we all have known and heard that there is a hypoxia, there is lack of oxygen, and there is the hyperoxia. There is a lot of oxygen given to patient can do permanent damage to his lungs, to his eyes and other organs. It's an essential drug. It's dangerous to give too much of oxygen. So we have to give the oxygen at the right LPM, that is the liter per minute, and this is the essential adjustment which can be done on the flow meter that is available at the oxygen points. Most of the flow meters in the normal oxygen beds support from 0 to 15 liter per minute of delivery, and the patient in the triage area, you should establish at what level of delivery is optimum for this patient to maintain his SpO2 levels above 92% constantly, and not allow them to fall below 92%, but not above 94%. This is a good range so that the patient doesn't have hyperoxia. And you try to maintain and stabilize the patient here and set the LPM, increase or decrease as per the demand. Every 2 hours, measure, chart out, check, shall I decrease the oxygen, shall I increase the oxygen, and keep the patient in this range. This is the simplest way you can achieve and save around 30% of your oxygen. Of course, there are more complex things in the ventilator settings, like increasing the PIP, reducing your oxygen delivery mechanism, reducing the LPM flow of the ventilator. Now there are a lot of clinical things which get involved. So I don't want to set it as a parameters. It is the discretion of the treating physician, treating doctor on what call he has to take. But yes, there are points where you can really increase the PIP, reduce the LPM and have the same effect on the patient. I would really love that my friends in the medical field will surely come out with a detailed video on this section, and I appeal to them for the so. But now in this section, we will deal with decreasing PIP, increasing PIP, decreasing the LPM, setting optimum FiO2. If there is no improvement by significantly pumping the oxygen, then you should stabilize the patient by stepping down a little and checking. That way you know that the patient is not going bad and is not improving, and long term may require to be on the ventilator. So this way, if you establish proper oxygen weaning protocol and monitor continuously, and in the next part B, we are going to look at many more techniques how to have this oxygen weaning protocol established and run properly into the hospitals. In this section, let us have a look at other issues which can be tackled so that your oxygen consumption goes down and you are successfully implementing the oxygen weaning protocol. Now, one of the foremost suggestions that I would give over here is have a concept of floor briefings. There has to be someone who has to go and conduct regular floor briefings on your hospital floor and make everyone aware that oxygen is precious. It is much needed thing in the COVID and it needs to be conserved. The second good concept that has come is use of a oxygen nurse. The job of this oxygen nurse, fixed responsibility, her job is to go around and ensure that the patients are only given at the right LPM delivery. Go inspect, check what others have been following. If they are not following the protocol properly at a certain patient, correct it. The oxygen goes waste in lunch times. I have seen oxygen wards where patients are having lunch and all the masks are on and the oxygen is flowing. We should educate everyone at the floor, the patient, to make and ensure that the oxygen weaning protocol implementation is a success, and that we should close the knob whenever the patient is not putting the mask and inhaling the oxygen. Now it might be having lunch, dinner, food, liquids, and going out for nature's call, attending nature's call, going to the washroom. And obviously there are some precautions to be taken in this area. If somebody is going for the bathroom and if he is having the saturations less and you are removing his mask, ensure that he has company. We have had a lot of cases of hypoxia, bathroom hypoxia. We call it bathroom hypoxia, where patient collapses into the bathroom because of lack of oxygen. There is a sudden fatigue that he has. There is no mask. There is no additional supply of oxygen. Another way is put signages. There is no way a patient is supposed to touch the oxygen knob. He is not supposed to set the oxygen settings. A lot of patients think that if they increase the oxygen knob and their saturation becomes 98, they are going to immediately be cured and they are going to walk out of the hospital. See that this notion is addressed, and a huge responsibility here on the head nurse of the hospital to see that this doesn't happen. Prepare charts every 2 hours, monitor the oxygen, reduce the LPM. If the saturation is going high, increase the LPM. If the saturation is going low, have an oxygen nurse, put signages, make the patient aware that oxygen is precious and is not supposed to touch any of the settings. Shut off oxygen in your lunch time, your dinner time when the patient is not using the oxygen. Also, in this oxygen weaning protocol, there is a lot of importance of correct pressure settings. If you increase too much of the pressure, if your pressure regulatory valve fails, there has been instances where there is a bursting of the humidifier bottles that takes place. So put the LPM deliveries properly. Sometimes when the LPM is 0, still there is a leakage of oxygen. Close your knobs properly. Check your humidifier bottles for proper kind of quality before putting them into the operation in the O2 beds. These are the very, very important precautions to be taken so that oxygen weaning is understood by everyone. It impacts your cost also. There are flow briefings. Your biomedical engineers are oriented over the pressures and your staff is oriented towards conserving oxygen, which is a precious national resource in this COVID times. So here again, there is an important step of displaying your oxygen protocol besides the signages of do not touch the oxygen settings at every patient's bedside. These signages should clearly explain the oxygen weaning protocol. In the ventilator section, in the HDU section, ICU section, there is a bigger role of PO2 measurement, and all your oxygen weaning protocol should be properly displayed at all points. And there is a concept, if your patient is crossing 9-day, 10-day, 11th day, there is a very high probability that his oxygen requirements are going to go down. So such patients should be monitored who are in the O2 section. Also, if it is possible, create a separate step down facility where the staff is oriented towards stepping down a patient, and this is possible in a large setup. A large multi-bedded setup should have a separate step down facility where the oxygen consumption per point is very much low and the staff is oriented towards stepping down when the patient is in the recovery phase. This is an important portion of the oxygen weaning protocol in the larger hospitals and the sections. Now it is important that once you have stepped down the LPM of the patient, you have to go back and monitor his SpO2 again after 10 minutes to see that he is in the stable range. This is of the paramount importance. So if you step down of a patient, you have gone ahead, maybe 2 beds, 3 beds, please come back. Check out his SpO2. This is mandatory. And then see if the patient is stabilized. If he is stabilized, then definitely you can continue with the lower settings of the LPM. Do not drastically cut down the LPM. Go stepwise. Go 2 LPM, 1 LPM, 3 LPM at a time as per the patient's saturation. You should not drastically cut down the LPM of a patient even if his saturation has gone to 96, 97. You have to reduce it by taking the judgment, and it is not advisable to have a drastic reduction in the LPM in the oxygen weaning protocol.